please help spread the message of Frequency Specific Microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about Frequency Specific Microcurrent.
Last week, I ran all over your list, so I figured this week that I would let you and your list start.
Okay. I almost wish, I do think we actually have to go back to last week for a little bit because it prompted, I don't know about you, but I got a bunch of emails sent. There's one, before we go any further,
Okay.
I have to clarify something that you said on January 22nd. Somebody wrote something in. So I didn't know what it meant and I didn't go back and listen to it. So I'll try to paraphrase it.
Okay.
It was regarding post-herpetic neuralgia. So the quote said something like, polarize the heck out of it. The current makes the voltage-gated channels in the nerve membrane flip over, forcing them, and then just knocks into them. They would like a little more explanation.
Oh, first you have to understand that first you have to Google voltage-gated ion channels in nerves.
Okay.
I can't describe that. They're nerve membranes fire. You get a action potential because there's sodium on one side and potassium on the other. And I'd love to pretend that I remember which one's which. I think sodium's on the outside. And anyway, so when the action potential comes along, the way it is propagated is this channel opens and sodium runs in and potassium runs out, and then it flips over again. And it does that. That's how the action potential goes along. So if you've ever had a nerve conduction study, there's this little spike that goes. Well, that is a sodium, potassium, voltage gated. So voltage gated means that there's that channel that lets the sodium in and the potassium out and lets the action potential go is operated by or influenced by voltage. All I know is that Terry Phillips calls them voltage-gated ion channels, and he knows a lot more than I do, so that's what I call them. And then, so I think this is my hypothesis, that one of the ways that FSM treats nerve pain so easily is if you run 40 and 396, if a nerve is inflamed, it stops conducting. The inflammation in the nerve stops conductivity. That is pretty good for relieving nerve pain. And it will also improve nerve atrophy in a muscle. But to get a nerve from numb to hypersensitive to normal, first you have to relieve the inflammation because that's what made it numb in the first place. But then, and that will help the muscles like show up. But to get the muscles to contract, whoa, that's weird. Get the muscles to contract and to get the nerve from hypersensitive to normal, sometimes you have to run increased secretions in the nerve, and the nerve has to be polarized. Nerves are polarized. We're positive centrally, negative distally. That means there's more electrons out here than there is here, right? Because electrons are negative. And I think of polarized positive, increase secretions, polarize positive, reduce inflammation as forcing the nerve membrane to work. And it's just, when I say drive it, that's exactly what I mean. You don't get to vote. You are going to work. This is how this goes. And as long as the nerve is still there, it usually works.
Yeah.
If somebody's cut the nerve, or if the virus has completely destroyed the nerve. So if you have post-herpetic neuralgia and the tissue is numb and painful, there are times when the nerve has been destroyed by the virus, like it's just not there. That's when you have basically phantom limb pain in your rib.
Right.
And you run 40 and 89 and hope for the best. Post-herpetic neuralgia is not easy. And it's like the more you know about neurology, the more you know you don't know.
Yeah.
One of the ways I went down the rabbit hole and screwed up the advanced list today was trying to add the frequencies for the cranial nerves. Because I finally, after 30 years, had a patient that had cavernous hemangioma that burst. And cavernous hemangioma is like a tangle of blood vessels that are pretty fragile. First, she had a bleed. That was a hemorrhagic stroke, but she had two little hemangiomas, one in her cerebellum and one in between the pons and the fourth ventricle. And then the surgeon said, so 6 months later, she recovered from the stroke. Then the surgeon said, those hemangiomas are still there. They could go anytime. So we should take them out. It's been 1.5 years since he took them out. And she has deficits in cranial nerves 3, 4, 5, 6, 7, 8, and 9 that have just not recovered. And I found out that George's experimental frequency for the facial nerve works. Yay. The accessory nerve kind of works. Some of the frequencies on his list for 2 of the cranial nerves are AB pairs, and I'm not sure what to do with those. So I'm going to put it in, but the question is, how often do people see these kind of really esoteric neurologic things? Nerve pain, everybody treats, at least I hope they do.
Yeah.
So
that phrase will always bring me back to my first core when you say nerve pain is going to be one of the easiest things that you treat. And I'm always a nerd and I'm always sitting either in the front row or I'm sitting in the very back row. But this course, I was sitting in the very front row. And I remember looking around being like, did anybody else just hear her say nerve pain is the easiest thing that we're going to treat?
it is. It's the easiest thing we treat.
Can you, while we're on the nerve, and I'm going to derail my own list right now, but since we're talking about it, I thought I would just jump on it. When you have somebody, can you explain, and maybe there isn't an explanation, how numbness goes to hyperesthetic and then it goes to normal?
Oh, it's like the reverse process. When a nerve first becomes inflamed, it becomes hyperesthetic, hypersensitive. So with a pinwheel, you have sharp or prickly, you have icky, and then you have numb. That's the progression of nerve dysfunction. If a nerve is numb, if you're lucky, the nerve is still there. It's just so messed up that it can't conduct anything.
Right.
Sensory is easier for us than motor.
Yeah.
But we can, because most nerves are mixed, sensory and motor, the ones that we deal with in the arms and legs and back. So when you go from normal to hypersensitive, the next stage of dysfunction is numb. When an area is numb. So I was treating an osteopath at a medical meeting who had open heart surgery, and he had a brachial plexus traction injury in his left arm, where his arm fell off the board as they were doing the open heart surgery. And he said his hand was so numb that he would blister his fingers taking a cup out of the microwave because he couldn't feel it. So I went, that's not that hard. Is it okay if I treat you? And he went, okay. And he's looking around the booth. And I just wrapped a towel around his neck and wrapped a towel around his arm. And we talked about his kids and his grandkids and his open heart surgery and my open heart surgery and blah, blah, blah. And after about 30 minutes, his hand and his C6 were, I used the pinwheel on him and he went, ow. I said, oh, that's great. He said, what are you talking about? I said, it was numb 30 minutes ago. The next step back towards normal is hypersensitive. What this means is the nerve is still there. It's not dead. It's not broken. It just has to be repolarized. If it goes from numb to hypersensitive, it will eventually go back to normal. May or may not stay there. Traction injuries are the easiest because there's no perpetuating factor. It just got stretched. And the stretching, if you think of it, you take those voltage-gated ion channels and you just rip them apart so they don't work. That's a nerve traction injury. That's how I think of them anyway.
And then nerve traction injury, do you focus on 124 first?
Nope, just 40.
Just 40.
And then 81. I guess I could do 124. I just never thought of it because I never needed it. So it might help. And I could just be a creature of habit. And maybe all it needs is current.
Yeah.
But it has always been 40 and 81 with nerves for me. So.
Yeah. Yeah, those are the very fundamental, basic factors, I think, when we're dealing with nerve pain. Okay, so that's that part. While we're on pain, though, we did a lot of viscera talk yesterday or last week. And what's that?
I said, it seems like yesterday.
It does. And I was thinking, because I'm getting treatment on my hip right now, and people are against me bringing my machine to my own treatment. So I'm treating myself first at home or in the car before I get, treatment done.
Wait, they won't let you bring your own machine? Okay. That's, never mind.
It's okay. So when people are trying to get in to treat your psoas, you know where I'm going with this.
You treat the psoas without 13 and 60. That's just insane. Why would you let them do that to you? The time. This is I'm changing hats now.
Okay.
To my patient advocate hat.
Yes.
My patient advocate hat is they work for you.
Correct.
And so the conversation is, we both agree that my psoas needs working on. I'm going to run a frequency while you're working on my psoas. That should make working on my psoas easier. They don't need to know that it's 13 and 60. And if they say no, you find a different therapist.
Which is why I've been on the run.
Okay.
Literally.
Sorry. It just.
No. I give people the benefit of the doubt. The problem is not really the problem. It's the eye-opening experience of knowing how deep the psoas is. Let's just think about this for a second. And iliacus. Okay, so psoas attaches onto the lumbar vertebra.
From the front.
On the front. And people are taking an anterior approach to go through everything that is on top. And nobody is taking their time and they're just using force. And all I can see is the micro trauma that is happening on top of everything. And like I said, I've been on the run.
The thing that was fun with this guy that we got on videotape last week, he's got just quite a tummy on him. But even with that, if you roll off of the rectus abdominis and the omentum, so you start in the middle, and I'm on his right-hand side.
Okay.
And you come to a ditch, you come to a soft spot. And that, if you hit it in the right place, you're on the lateral edge of the psoas because it goes, the thing is this wide. And so you go on the lateral edge of the psoas, you run 13 and 60, and underneath all the visceral organs, you don't go through them, you go lateral to medial, and you hit the psoas and you could, or the ureter, and you can tell because the muscle splints up and the patient makes scrunchy faces.
Right.
You just back off and wait for it to soften. And then you just roll it medial. And when it gets stiff again and they make scrunchy faces, you stop and you wait. And then it softens about 1 millimeter, and then you roll it another 3 or 4 millimeters, and then you wait. So there's no, yeah.
There's, in a perfect world, that would be the approach that everybody would take to treat the psoas or the iliacus. However, I'm here to say that is not the approach that some therapists take.
Why would
And
you let them do that to you?
I don't let them. I have left. I have said, I don't think this is the right approach for me. Can we move on to something else? And I'll get somebody else to work on my psoas, I promise. And that someone is me.
Like,
And
I'll see you in March. That
yes,
will be easy.
yes.
That'll work.
Yeah, but it got me thinking, because I don't know about you, but when I get worked on, I start overanalyzing. What are they on? What are you doing? Why are you doing what you're doing? And I'm thinking, why did the tissue get like this? Because I am a good FSM clinician. So when I am treating others, I'm thinking, how did we get here? So when it comes to scarring, like scarring is one of my obviously favorite frequencies. We talked about this, I think, podcast 1. If you were on a deserted island and you could bring 5 8 channels with you, I think 13 would easily make that list for me.
Top
Am
5.
I,
Yeah.
am I freezing or are you freezing?
I don't know. I'm not freezing. You're
good?
freezing on and off, but not for very long.
Okay. Maybe it's electricity today. But now that I'm thinking more and more, how did the scarring get here? Why did the scarring get here? 13 isn't the holy grail that it once was. It's necessary and it's useful because it will help with the adhesions and it will help with the scar tissue. But I have to think more now. How did we get here? Was something inflamed first? Did something tear first? Was something traumatized first? Was something...
I've got one
What?
for you. Patient's presenting complaint is swelling and pain. She's a runner. Presenting a complaint is swelling and pain in her knee. And the MRI shows, the MRI report says an intact meniscus, but she has pain on the medial side of her knee, so I don't believe it. And chondromalacial patella. And when you look at her knee, it's a centimeter larger than her right knee. And the patella is pulled over to the lateral side. So the vastus lateralis is too tight, pulling it out. The quadriceps is too tight. She's got hyperesthesia in all of the cervical dermatomes and is very ticklish all over. This is interesting. So I'm working on her leg and find out that her hamstrings are like guitar strings. They're really, really tight. So the first visit I ran 40 and 10 and 81 and 10. Why are you doing that? Because your hamstrings and your quads shouldn't be that tight. And the knee pain didn't start until after she had a tummy tuck and liposuction. And the nice man did a liposuction on her back. And L1 was numb from where the incision was in her abdomen, but L2 and 3 and 4 were all way hypersensitive. And she said, I want you to fix my knee. And I went, unfortunately, your knee is not the problem. It's the symptom. But before the surgery, you didn't have any knee pain. And after the surgery, your patella is tracking to the left. And I'm thinking to myself, you really need to go to Livermore and see Kim, but she's got 3 kids and she doesn't have time. So I had to channel you. And I thought, wait a minute, what did he do? He did a liposuction around the lumbar spine. And L2 was, I think the technical medical term you use is pissed off, was irritable. That would make the vastus lateralis cranky as well. So the day we made the most progress was the next day when I ran 124 and the meniscus for an hour. I ran, so torn and broken, repair and heal the meniscus, because she has pain at the joint line on the medial side. The only thing that does that is the meniscus.
Mhm.
And then the patella is just getting ground down in the groove. So I did inflammation and I think necrosis in the patella, but inflammation in the patella for an hour, inflammation in the periosteum for an hour, and inflammation in the nerve for an hour. So she had 4 machines on her left side, and I went over on her right side and started taking apart the scar tissue from the tummy tuck and liposuction.
Right.
And at the end of it, for the first time, I think it was the 3rd session, she got up and she's walking around and she's so excited. She said, it doesn't hurt. It's still 0.5 centimeter bigger. There's still diffuse swelling, but it didn't hurt. They did an MRI of her knee. Nobody, none of the physical therapists, none of the surgeons, none of her GPs, nobody that's seen her has tested her sensation. Nobody has done her reflexes. So that is why, that's the other reason FSM practitioners are special. It's like you can learn an awful lot with a pinwheel.
Yeah, it's been a huge adjunct to my assessment findings. I'm a biomechanic geek. I'm also adding fascial lines and that kind of movement pattern in, and everything complements the other thing, right? The thing about FSM is it allows you to think outside the box and cross-reference. And you said it before, it's pattern recognition. So once you see something once, it's impossible to unsee it. And then you start seeing it everywhere. So I do think it always has been beneficial when somebody comes in with pain in their knee to not be so myopic and just look at the knee, to do your assessment and think, could it be coming from the hip? Could it be coming from the back? Could it be coming from...
And the other question you ask is, what happened just before this? I had a tummy tuck in November and I got knee pain in January. Those are not unrelated. It's not, what is it? Before, therefore, because. Not necessarily. It's not always this happened before, therefore what happened afterward has been caused by what happened before. But in medicine, at least, they're usually related. Right.
Yeah. Side note, I've been binge watching this old show on Netflix called The Resident, and I love medical dramas.
It's called what?
The Resident.
Oh, good. Yeah, okay. I've never seen that.
He's an internal medicine doctor and he does pattern recognition. And I just keep thinking he would be so good at FSM. And I
Yeah.
realize he's not a real doctor, but I credit that type of thinking. I value that type of thinking so much more because, and you've said it time and time again, you don't think about these areas because before you never had a tool to treat it. So who cared about the dura, really?
Yeah.
I mean, who cared about the periosteum? Who cared about the fascia? Who cared about the omentum? We knew it was there, but the respect that you have is more profound, I guess, with FSM.
You have a way of affecting it. So I love my dear friends who are fashionistas, and they think it's the fascia, they think it's the muscle, but and this is why I say with all honesty, I'm a terrible chiropractor because I don't think bones do anything. They either move or they don't move. And if they don't move, there's a reason they don't move. Muscles move bones, nerves move muscles, the brain moves the nerves.
Right.
And it's like you just have to find out where along that chain
Yes.
things went wrong.
Yeah. And I don't think that is far off. I think a lot of therapists do, when we do our assessment, we're trying to figure out why isn't this working? Why is this not firing the way that it should? But now you just have so much more support in your treatment plan after figuring out the cause.
Yeah. I've seen biomechanical feedback people do some amazing things. Here, a push on this and then do that and then do this and then do that. And whatever the problem was goes away. The question is, how long will it stay? Did you fix it? Strain, counter strength, great, terrific.
Yeah.
Will it stay fixed? I don't know. Yeah.
The staying fixed is it's my love affair. That's where I take that part very seriously. I guess once you start getting good at what you can do with your hands in the clinic, the real challenge is how can we keep these results as permanent or as long lasting as possible? And I do believe with everything in my heart that it comes down to feeling safe. Body has to feel safe to create the movement and the contraction. Otherwise, nothing. So the real work, I think, begins with, so I think, yes, what's happening? How did we get there? And then after that is, how can I create a safe environment? How can I get this nervous system to believe these changes are safe and the movement is going to be safe?
And this lady with the knee said, I'm just really ticklish. Well, ticklish goes up the pain pathways. So when I did the sensory exam, she was hyperaesthetic from C2 to S2. Like she had two nerves that were not hypersensitive.
Wow.
So I ran 40 and 10 and 40 and 92. And it wasn't until the second day that I needed to run 81 and 10 to loosen the hamstrings. But safe ticklish is not safe. So she said, how are you going to make me not ticklish? And it's like, we just talk to the sensory cortex until it's safe. We just dial it down a little bit. And so you run 40 and 92, quiet the sensory motor cortex. And I've never had it not work. It's like I couldn't touch her abdomen to work on the liposuction scar because I couldn't touch her abdomen. She's so ticklish. You can't treat somebody that's levitating. So I ran 40 and 92 for, I don't know, it took 20 minutes, which is a really long time. Usually it's 2 or 3. That's what made me at 40 and 10. It's interesting.
Yeah.
So it's like the body had to feel safe. And there's something about nerve hyperirritability or hypersensory awareness, whatever ticklishness is about, and is unsafe.
Yeah. There used to be a trick that we would do, especially again, it's like the psoas going into the abdomen. If they were ticklish going into rec fem area, iliacus, to put their hand down and then you put your hand on top of it.
That works.
Yeah, but it's just nicer if you don't have to involve more things on top of where you're trying to go sometimes. There's a lot of questions, one or like a couple case studies. So I want to jump to Summer's really quick because we're on the nerve sort of train right now. She says on nerve inflammation, you said 40-396 polarized. And are you also saying 81-396 polarized too? Just want to be sure I understand that. I have a client with serious leg nerve pain, major fasciculations from back surgery. So I imagine scar tissue involved too. So 13-396 too.
Run 40 and 396 first so that you can touch the nerve, and then take the scarring out. And then you can try fasciculations is when the muscle is denervated. So then you do 81 and 396, or even sometimes 81 and 10 to get rid of the fasciculations. That shouldn't be a thing after low back surgery. That's curious. Yep, you're on the right track. Keep in mind, you might have to run 81 and 10. I know what sounds like I know what I'm doing, but you guys understand I make this up as I go along, right?
When it comes to nerve pain, we just talked about two A channels, 40 and 13. How do you discern which one to use?
Oh, you always use 40 first because any nerve that's scarred is inflamed.
Yeah.
So one of the techniques in research for creating nerve pain or simulating nerve pain is that they go in and they just tie a knot around it. They put a piece of thread around it, basically create scar tissue on the nerve. So you have to run 40 so that you can touch the nerve. And then on a second, 13 and or 81, and then you follow the nerve along its path and release it because it can be scarred just about any place. What'd you do? Your hand.
But oh, I
What'd you do
burnt
to your
myself.
hand? You have a Band-Aid on.
I burnt myself.
Oh, okay. As long as,
But-
yeah, I actually got a cold, a flu, sinus infection, all those things. It's the bug that's going around. Just in case it's viral, I've been running long COVID every night.
Yeah.
And then just in case it's bacterial on top of viral, I started on augmentin yesterday. There's
you're looking sound.
More than one thing.
Summer just asked about timing.
Say again?
Summer just asked about timing. I'm guessing about the nerve frequencies.
Summer asked about, I lost Summer.
Oh,
What about timing?
Yeah.
I erased it. You run 40 and 396 until you can touch the nerve without having the patient jump. So you run 40 and 396 for maybe 3 to 5 minutes while you're setting up the second machine to run 13 and 396. So if you're moving a nerve that's scarred, it's a pretty good chance you're going to traction it, which will increase the pain. So if you have one running 40 and 396 constantly, then you can treat the scar tissue easily. And that way, if you tug on the nerve and create a traction injury, it's not going to hurt anything. So it's where multiple machines come in handy, even if they're custom cares. You have one that's 40 and 396, the second one were single frequency combinations.
Yeah. I'm going to jump down to Jennifer's question because it's a little bit easier to read than the other ones. Just quickly, she has a client who has ataxic gait, works as a pool cleaner, undergone MRI, showed no abnormalities in his brain. According to PT, x-rays are good. She does an assessment and there are no reflexes. Sensory, everything is sharp. Touch, super sensitive on paraspinals and stomach. C3 is in an anterior position. He has shallow breathing when attempting to stand and stabilize his balance. He's seeking the PT for that. Began treatment with concussion, sympathetics, vagus nerve, emotions, inner ear frequencies. However, even with light touch on the neck, he has discomfort, raising his chin, reporting a sensation of suffocation. Muscles do not feel particularly tense, did not observe the expected smush effect.
They did an MRI of the brain, and it's normal.
What it says.
23 years old. It just so everybody knows, ataxia, when I had that herniated disc in my neck that was pushing on the motor pathways,
Yeah.
and I had a positive Babinski on the left and spasticity or increased tone on the left. One of the neurosurgeons said, oh, some people wait until they're ataxic before they come in. So ataxia does not always come from the brain. I don't know that much about it. All I know is people that come in with an ataxic gait is coming from the spinal cord. But if the spinal cord is compressed, you'll have hyperactive reflexes. This guy needs to see a neurologist that isn't an idiot. But like somebody did an MRI of his brain, but
How about an MRI of his neck?
MRI of his neck would be good, but a neurologist would also be good. You did all the things. The only thing I would try would be 40 and 10 or 81 and 10. Raising his chin. Suffocation means that's the medulla. Muscles don't feel tense. That's weird. Also expected.
It said she ran 40 and 10, but only for 15 minutes.
And it didn't do anything. Yeah, it's in a 40 and 10 patient, the patellar reflexes are active. And you're saying that you didn't get any reflexes anywhere. And there's two possibilities. You're a massage therapist. So one is you might not be doing them. That's a possibility, even for me. And having no reflexes it doesn't go with what I know about ataxia. Wait, Jennifer said what?
Oh, it's not on the Q&A. Oh, she wrote in the chat, she agrees, but so did PT.
Yeah, that's weird. I don't know. Yeah, it's getting reflexes is not always easy. Took us 10 weeks. And even now, C7 is one that escapes me sometimes. Okay, so they only did a neck MRI, a neck X-ray. They did a brain MRI. Neck MRI might be a good idea. C3 is anterior, which means it's translated. And the only way to tell if there's cord compression is an MRI of the cervical spine. Raising his chin sounds like Dura, doesn't it?
Yeah, I have that image, right, of trying to keep
That,
right?
yeah. C3 is anterior. And the other thing is that a C3 disc is like, if you do the little pinwheel thing, C2, C3, C4, what are these nerves like? Sensory, everything is sharp, touch, super sensitive on the paraspinals and any stomach area. Wait, the thoracic paraspinals are hypersensitive? And so the stomach area is the thoracic paraspinals. Okay. So take two. Go back and find out what happened before all this started. The thoracic paraspinals, super sensitive, so hyperesthesia on the thoracic paraspinals and on the stomach area, those are thoracic. And you can actually get a thoracic disc herniation. So the question is, did he fall on his butt?
He's a pool cleaner, so that's what I'm thinking of.
Slipped on the pool deck?
Yeah.
Oh, he wore a helmet when he was a kid because he always fell?
So has there been like a balance issue since the dawn of time? I'm just thinking vestibular.
It's the thoracic paraspinals that makes me nervous. The only patient I've ever treated that turned into an overnight quadriplegic was a guy with a T7/8 herniated disc that was pressing on his spinal cord. And the surgeon didn't use enough steroids when he took the vertebral body or the spinous process and the lamina off. He didn't use enough steroids, and the disc and the cord blew up and sheared all the nerves. So sounds to me, but see, that should make his patellar reflexes hyperactive. That should make the patellar reflexes hyperactive.
Right.
Somebody needs to order a thoracic MRI. I think something is pressing on his spinal cord, and if the ataxia is not coming from the brain, then it's coming from someplace. And you said that he fell all the time when he was a kid. So this is something he could have lived with for a really long time. You can try 81 and 10, alternating, don't polarize it. If he's bad enough to be ataxic, and if it is coming from a disc, it's something you probably ought to run alternating from next to feet. Don't polarize it. Because if there's cord compression enough to cause ataxia, there's cord compression enough to cause problems with polarization too. Suzanne, 66-year-old male with chronic lymphocytic leukemia. What? Okay, treating the lymphocytic leukemia. They're waiting for it to get worse. We just have to move past that. August fell with vasovagal syncope, intubated, heart attack, and cancer before ID. Infectious disease. Infectious disease confirmed West Nile virus. 2 weeks in the hospital, 1 week in rehab. Walker couldn't lift his arms. 3 miles used to assume. Okay. Okay, you can treat the nerves. Everybody else seems to be ignoring the chronic lymphocytic leukemia, so I guess you can too. Don't treat the immune system. And West Nile virus, the only thing I think we have that's close, it's not in the herpes family, is it?
No idea.
Epstein-Barr family? I don't remember. But I'd go through all the viruses we have, 38, 41, 44, 56, 160, 189, and do it with the spinal cord, the nerves. Yes, there you go. Facebook suggestion, 160 for viruses in 10, 396, 109. Okay, but put a pulse oximeter on him. Initially, first treat the right arm. No, treat the left that has more deficit. I'd go with that. It's going to be the easier to fix, probably. Or you could start on the better one. Ask him, basically ask him if he's left-handed or right-handed. Which one does he want fixed? Which one bothers him more? Because we do work for them. Oh, okay, we're going to leave this client number 2 alone, and she is so far outside your scope. You really chronic pain, mono, herpes. Yeah, it's that one's, I'd find a DO, a PT, or an MD to take this one. Chronic hip, back, neck, elbow, leg, and okay, that sounds like 40 and 10. She's had 6 auto accidents. So that sounds 40 and 10 and vagus, concussion and vagus. You could do that easily. Uncontrollable seizures. That sounds a little scary. Yeah, it's knowing when you're outside your scope. Oh, yeah. If they did an MRI of the brain, the radiologist would have checked for a Chiari because brain MRIs stop at C1 or 2. So Alpha's talking about the guy with ataxia with the normal brain MRI and hyperesthesia in the thoracic spine, and nobody's done a thoracic MRI. But they did do a brain MRI, which then a Chiari and tumor in the medulla will cause ataxia and the cerebellum as well. If they did an MRI of the brain, they would have checked for a Chiari. And Catherine, what question am I answering? That's a really good question. I just went all over the place. Sorry about that. Did I lose everybody? You're muted.
My dog started barking, so I just put myself back. It's easy for us because we see the questions popping up. So I think the question
Oh, nobody else sees them? Oh, wow.
I don't know if everybody can see them or if they just check on it.
No. So Summer is correct. Chronic lymphocytic leukemia is cancer, and we don't treat that. So as long as you don't treat the immune system or the bone marrow or the blood, you're fine.
People on YouTube can't see the questions, though.
Say again?
The people on
YouTube can't see the questions.
Oh, the people on YouTube can't see the questions.
It's
okay.
just our little immediate group that gets to see it. So that's why we have to read them and talk about them. So sorry, YouTubers. But yeah, I think one of the common things while we're on it is treating people with cancer completely contraindicated.
Say again, you froze.
I did freeze. I
tried to see that. You did freeze.
Yes. Oh, we're almost done.
I'm sorry.
No, one of the questions that we get a lot is people with cancer, is treating them completely contraindicated?
No, you can't treat the cancer.
Right.
You can treat concussion.
Yeah.
You don't treat the vagus because the vagus suppresses the immune system. So you don't want to treat the vagus, but you can, according to Harry, treat concussion, support the adrenals, treat the emotional factors because they're scared to death. If they're refusing medical care, you can treat bone mets and you can treat the pain from the cancer. If they're having traditional cancer therapy, you can treat toxicity from chemotherapy. You can treat radiation burns during the radiation to prevent scarring. You can treat preemptively, you can treat peripheral neuropathy from chemotherapy. So the cisplatin family of chemo agents universally, I can't remember what the percentage is, but it's pretty high. So we had one practitioner who treated his blood vessels from knees to feet with chemotherapy, peripheral neuropathy from toxicity. And these days, they are also, during chemotherapy, using ice on the lower legs to reduce the circulation in the lower legs and reduce the amount of chemo agent that gets to the blood vessels in the lower legs so the nerves don't get damaged. Carcinoma toxins, there is a number for that, but we don't use it to treat cancer because we don't treat cancer. So I'm not even sure what carcinoma toxins are, Leaf. I'm going to see you next week, I think, or the week after, so I can ask you what Harry thought about that. But once a patient has been diagnosed with cancer, or once I suspect cancer, I'm done. I'm not done. I do concussion. I do the adrenals. I do emotions. I do immune support. I think those are the 4 things that Harry did. Adjust the spine. That's the other thing he did.
Yeah. We have a minute left. I'm going to bring this meeting to a close and say, if you have not yet registered, if I'm frozen, I'm sorry. For the advanced, the sports courses are almost full. I think there's 2 spots left. And because we're in the one room, we can't pack very many people in. Please sign up if you haven't yet. And please come because it's in person and I can't wait to see everybody.
It's going to be so much fun. We have 28 people already for the core. We
Wow.
have 28 people for the core, so we have room for how many more? 2 more? 10 more?
I'll take up to 40.
Kevin says he'll take up to 40. I love whoever it was that said after 6 auto accidents, perhaps slipping TTH in one of those sessions should be considered. And yeah, I'm excited for Phoenix too. I'm working on my slides.
Yay.
Yay.
All right,
And
everybody.
we made it. It's 4 o'clock.
Sorry about my glitchy connection today.
Internet is internet.
Yes.
I'll see you next one. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.